morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences of the ACNS webinars in different parts of the world. Welcome back to yet another edition of ACNS webinars. We are really honored to host the first webinar of the month of December with one of the world's outstanding brain tumor researchers, Professor Jala Rezade from Toronto, Canada. Professor Zade is a professor at the Department of Surgery, University of Toronto, and head of neurosurgery at the Toronto Western Hospital. She leads surgical oncology at the Princess Margaret Cancer Center and is a senior scientist at the Princess Margaret Cancer Research Institute. She holds the Wilkins Family Chair in Brain Tumor Research, focusing on building surgical clinical trials for brain tumor patients. Internationally, she is the president of the Society of Neuro-Oncology and editor-in-chief of the Neuro-Oncology Advances, an open access journal of Society of Neuro-Oncology and European Association of Neuro-Oncology. Her clinical practice focuses on skull-based neuro-oncology with dedicated general brain tumor clinic and many multidisciplinary clinics that she has established at the UHN, such as skull-based pituitary brain metastasis, gamma knife, and neurofibromatosis clinic. We are extremely honored to have her today as a speaker at our webinars, and she'll be talking about translational research for brain tumor surgery. The second speaker of today is our leading figure in minimal invasive brain surgery and our honored guest from Japan, Professor Kazuhito Takeuchi. Professor Takeuchi is a clinical associate professor, Department of Neurosurgery, Nagoya University, Aichi, Japan. He is the counselor of the Japanese Society of Neuroendoscopy. He is also the executive member of the International Federation of Neuroendoscopy. He is a noted author who has published several articles in various peer-reviewed journals. We are extremely honored to have him today as a speaker, and today he'll be talking about endoscopic cylinder surgery for intraventricular lesions. The chair for the first session of today's webinar is our distinguished senior faculty from Japan, Professor Yoshitaka Narita. Professor Narita is a professor and head of Department of Neurosurgery and Neuro-Oncology at the National Cancer Center Hospital, Tokyo, Japan. He is the co-chair Neuro-Oncology Education Committee, WFNS, and the director of Japan Society of Neuro-Oncology and the Japan Neurosurgical Society. He also serves as the head of committee of the Brain Tumor Registry of Japan and the Committee on Guidelines. He also serves as the director of Japan Society of Intraoperative Imaging and Japan Awake Surgery Association. He specializes in the treatment of gliomas, malignant brain tumors, and neuro-oncology and molecular biology. We are extremely honored to have him today as a chair to chair the session of Professor Jala Rezade. The chair for the second session of today is our honored guest and senior faculty from India, Professor Yadram Yadav. Professor Yadav is the director, Super Specialty Hospital and School of Excellence in Neurosurgery, Netaji Subhash Chandra Bose Government Medical College, Jabalpur, India. He was the past president of the Neuroendoscopy Society of India. He is the author of the famous book, Neuroendoscopy, A Comprehensive Approach. His clinical practice is focused mainly on minimally invasive endoscopic brain surgery, and he also runs one of the most sought-after endoscopic fellowships in India. He has published several articles in various peer-reviewed international journals and was a co-editor of Neurology India Journal. He has been honored with several awards for his outstanding contribution towards neurosurgery. We are extremely thankful to him for accepting our invitation to chair the session of Professor Takeuchi. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome all the chairs and speakers and all the wonderful audiences to this online platform of ACNS webinars. A warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Seng from Malaysia is my co-host for today. And with that introduction, I would like to hand over this platform to our first chair, Professor Yoshitaka Narita.
Hello and good evening, everyone. Today, we invited Professor Jala Rezade. She had a great success of no meeting just last week. So congratulations. So title is Translational Research for Brain Tumor Surgery. So please start the lecture, Dr. Zade.
Great, thank you so much. I just want to be sure my internet is working and you can hear me. It's a pleasure to be able to speak with you today. I was hoping that I can show you some of the work that we've done in the lab on how to translate brain tumor research to help us as brain tumor surgeons and integrate molecular profiling of brain tumors, leveraging epigenetic signatures primarily. I have no disclosures. I have no conflicts either to report. I'm the outgoing president of the Society of Neuro-Oncology and will serve for a 2-year period as the past president with some responsibilities. And as you heard earlier, the editor-in-chief for Neuro-Oncology Advances, which is a open access journal for Society of Neuro-Oncology and the European Association of Neuro-Oncology. I'm proud to have become the chair of neurosurgery at University of Toronto September of last year. We have a great team of neurosurgeons between 4 hospitals, all extremely accomplished, and it's really my honor to be able to lead this group. So brain tumors come in wide varieties. Majority of them are tumors that we can in fact manage surgically. Pituitary macroadenomas can be resected fully surgically with no adjuvant treatment often needed after resection. The patient's vision is restored. This is a tumor that I would resect purely endoscopically, and the patient does well for postoperative period with no radiation, chemotherapy, or recurrence. A tumor that we deal with and has evolved in practice over the last 2 decades are acoustic schwannomas. These are tumors that at our center, unless they're larger than 3 to 3.5 centimeters, we treat them with gamma knife, as you could see with the frame fiducials here. Otherwise, the surgeries then become more complex, and that's an area that I focus on as well, with acoustic schwannomas being one of our areas of interest clinically and research. Another tumor that is a major interest and focus for us in the laboratory are meningiomas, which I'll speak to you later in the course of the talk. And we have most recent data to demonstrate that molecular integration allows us to better understand the biology of the tumors and improve on classification. The tumors that continue to evade us are the glial type tumors, in particular glioblastoma. At the time of presentation, the tumor has invaded far beyond the critical mass that we could see on the scan. And although we're able to resect the quote unquote lump that we see on the scan, we know that at the time of diagnosis, there's already a significant number of tumor cells that have invaded beyond that critical mass. And these are the cells that cause the challenge, present invasive and resistant cells that lead to recurrence. And majority of the research continues to focus on glioblastoma, and this is areas that we work on as well. Meningiomas are hopefully where I can show you majority of the work towards the second half of the talk. If we look at the management paradigms for brain tumors, currently it's fairly straightforward. A patient presents with symptoms and an MRI is done where a diagnosis is made. Either the tumor is concerning and they go on to surgery, or the tumor can be continued to monitored with surveillance imaging. And after surveillance imaging, if they develop concerning features or patient's symptoms progress, they go on to surgical resection. Currently, it takes approximately a week to 10 days, sometimes perhaps more, to receive a pathology diagnosis, in addition to some molecular features such as IDH mutation, 1p19q status, and MGMT methylation. Thereafter, the patient goes on to chemoradiation, and following that, perhaps if they fail, they go on to clinical trials. However, unfortunately, the results of the clinical trials in our field have been quite limited. So I'd like to present to you that the work that we've done in the lab, there is some data that will alter how we approach brain tumors, modernize perhaps the treatment paradigm that I showed you with respect to diagnosis, prognostication, and prediction of outcome, and being able to use circulating biomarkers. If we look at the WHO classification, there are over 150 distinct brain tumor types defined, and most recently, in 2021, Lewis et al. Came up with a more recent classification of the WHO that integrates additional molecular features. In the last 2 decades, integration of molecular features into histopathological diagnosis has increased, with histology being previously the mainstay of diagnosis, dividing the glial tumors, for example, into astrocytoma, oligoastrocytoma, oligodendroglioma, to now recognizing that gliomas are divided based on their IDH status to IDH mutant versus IDH wild type. And if they're IDH mutant, we look at the 1p19q status if it's co-deleted, or if it's intact and has p53 mutation, and so on and so forth. This is an evolution in our understanding of gliomas, and I would propose that most likely similar evolutions would continue so that we refine our understanding of different brain tumor types. And this will bear on how we understand the behavior of the tumor, the treatments that we offer, and aggressiveness with which we pursue them. A seminal work that was published in 2018 and presented in Nature demonstrated that over 82 different tumor types, when analyzed by methylation, show a very distinct molecular methylation signature akin to a fingerprint, where IDH mutant tumors versus IDH wild type have a very distinct methylation signature. And whether you have pituitary tumors of different subtypes have a very different signature on methylation. And so you could see that methylation can be used, in fact, as a classifier to layer on top of the WHO classification. And methylation, in fact, in this study showed that for all comers, improves the diagnosis by 15%. So I'd like to present to you some work that we have done at our institution that will modify the extent of our ability to diagnose tumors and make more accurate diagnosis by integrating methylation. And in addition to the methylation signature, providing us with the molecular signatures as well. In 2015, when a neuropathologist who was at our institution at that time, Ken Aldape, introduced methylation to our institution, and we have continued to pursue that program at University Health Network at Toronto Western Hospital. We chose to go back and look at our experience and reviewed the cases that we analyzed by methylation between 2015 and 2018. We found that we had analyzed the tumors by methylation of approximately 1,700 cases, and we used inclusion criteria for methylation to study for the publication to have challenging cases where two neuropathological diagnosis or two expert neuropathologists would not be able to reach consensus. If there was a distinction between what we as clinicians, primarily the surgeons, felt the tumor looked like to us and what the pathological features showed. And then also there was a need for molecular subtyping. Based on these inclusion criteria, we identified 55 cases during this period. And you could see here that we created in our process of introducing methylation an integrated diagnostic workflow where we took the histopathological diagnosis, we integrated methylation copy number and methylation classifier based on what I showed you of that earlier publication. And if there were molecular signatures that needed to be reevaluated, they were retested, and a reintegration and a reevaluation with a new diagnosis was generated. In so doing, 24% of the patients had a change in diagnosis, 31% had a resolution of their differential diagnosis. There was an increase in the WHO grade by 18%, a decrease in the WHO grade by 5%, and where previously a WHO grade could not be assigned, 4% received a WHO grade classification. Additionally, you could see the molecular signatures that were detected using methylation. This is a plot that demonstrates the original histopathological diagnosis and the final integrated diagnosis using methylation, copy number, and methylation classifier. And you can see that there's a significant number of crossover from the 55 cases that we selected for this study. The most noteworthy next step was to say, well, if the diagnosis is improved and refined based on methylation, does this in fact impact the outcome for the patient? And so we looked at what alterations would have been introduced in the management of the patient. And you could see that these are examples of tumors where the original diagnosis had changed based on the integrated diagnosis. And as a consequence, the treatment plan changed where radiation, for example, was withheld. And that's a significant impact because the negative adverse effects of radiation are eliminated. And sometimes perhaps the nature and type of modality of radiation was refined. The first case that I highlight is the most noteworthy case where a young girl who had seizures and had a tumor resection in an institution outside of ours had a tumor that was then classified as high-grade glioma, not otherwise specified. It was IDH negative, and 3 pathologists were not able to reach a consensus. Based on the features of high grade, there was a concern for the behavior of this lesion, and so chemotherapy, temozolomide, and radiation was recommended. At the same time that the discussion was taking place, the father of this young girl sought us out, and we did the methylation. The methylation, in fact, demonstrated that the tumor was a DNET. And as you know, the DNETs require no additional treatment. And so the recommended management plan was observation, and we were able to avoid radiation and chemotherapy. And she remains stable almost now 5 years after the original event. And most recently, she sent me an email, a very heartwarming email, to say that she's entered medical school. So to us, in summary, the results demonstrated noteworthy findings. 84% of the diagnostic challenging cases that I identified for you based on the criteria that I outlined had a meaningful change in their tumor classification. 24% of that was a change in diagnostic entity, 31% was a resolution of the differential diagnosis, and 27% was a change in grade. 15% of the patients had a change in clinical management during the period that we studied. As a result of these noteworthy and impactful findings, methylation has now become integrated into our clinical practice, and we use the results in decision-making in our tumor boards. This work was published in Clinical Epigenetics. The first and two co-authors are Shireen Karimi and Jeff Zuccato. Jeff is a PhD student and a neurosurgery resident in my lab. Mehmet Yasin and the rest of the team are those who contribute to the methylation program. I'd like to recognize the Princess Margaret Cancer Center for supporting the methylation program. And as I mentioned, Ken Aldape, who is our collaborator and continues now that he remains at NIH. Please stop me if you have any questions as I go on to the next section of my talks. When we look at the histopathological section of a glioblastoma, I think for all of us, it's very straightforward to recognize that there is a central necrosis surrounded by pseudopalisating hyperproliferative cells that are invasive. These are thought to be the resistant cells as they've moved away from the areas of hypoxia and can survive as harsh microenvironment. And there's endothelial cell piling, creating abnormal structures that are called glomerular tufts, as they resemble glomerular structures. If we, however, look at this section, this appears to be a normal brain section. This is a section courtesy of Professor von Deimling and DKFZ. If you draw your attention to the circles, you could see, however, on this section, if we do an IDH stain, that there is positivity for IDH mutation, telling us, in fact, that this is not a normal brain section, but rather there is evidence of IDH mutation and therefore a low-grade infiltrative tumor evident in this patient. Why is this important? I showed you earlier that gliomas are now divided based on their IDH status into IDH mutant or wild type, and further subdivided based on their 1p19q status. And this matters because the prognosis for the patients are vastly different. A high-grade glioblastoma or grade 4 glioblastoma, grade 4 glioma with IDH wild type has the worst prognosis compared to a low-grade glioma with IDH mutation and 1p19q codeletion. How we counsel the patient and decisions that we make, of course, matter based on the prognosis and the curves that we follow. So for a patient such as this, a young man who presents with a focal seizure and an MRI where a lesion is obvious, I think the audience will be divided as to whether we would recommend treatment upfront with surgical resection or surveillance monitoring. And when we look at the paradigm that I showed you earlier, this may very well be for a lot of us a decision that we would ask the patient to go on to continue close surveillance monitoring and MR imaging until the imaging features change. I would submit to you that perhaps if we had a liquid biopsy, a plasma test that could tell us the IDH status of this tumor, in addition to other molecular features, we would make a decision differently. We would perhaps advocate for earlier surgical resection versus surveillance, or vice versa. When there are tumors in our system, we know that they shed small pieces of DNA into the circulation. We can then capture those small pieces of DNA and study them. We know that tumors carry mutation. And if we take the circulating free DNA in our bloodstream and sequence them, the likelihood of finding those mutations repeated on the same pieces of small DNA is low because the abundance of mutations is low. And so looking at mutational patterns or circulating free DNA, it would be akin to looking for a needle in a haystack and makes that challenging to use for diagnostic purposes. However, what is conserved on the whole piece of DNA throughout the system of the tumor and what's shed into our plasma is the epigenetic alterations in the methylation signature. And so we can mitigate the concern of a needle in a haystack and use methylation signature and rely on that redundancy to be able to accurately diagnose the patient's tumor and its molecular subtype. My colleague and senior scientist, Daniel DiCarvello, published in Nature in 2018 and showed that, in fact, if you take a series of brain tumors and take plasma, sorry, not brain tumors, a series of solid tumors, not brain tumors, and take their plasma and compare that to the patient's tumor signature in the plasma and compare that to normal plasma, you could see that the tumor methylation signature in healthy versus, for example, in this case, pancreatic cancer is very different. And the methylation signature in the plasma matches that of the blood, of the tumor. So here you could see that there's a range of different tumor types that they demonstrated this. For example, in AML, the plasma circulating free DNA methylation is 1-to-1 with the tumor. For BRCA positive breast cancer, there's a high AUC where in the plasma methylation, it matches that of the tumor and can be used for diagnostic purposes. For lung cancer, pancreatic cancer, renal cancer, similarly, the signature in the plasma matches that of the tumor very closely with high accuracy and therefore can be used as a diagnostic tool and, importantly, perhaps used as a surveillance tool. So with these positive results and promising findings, we thought, can we actually look at plasma methylation signature in brain tumors? Since there is a concern that the blood-brain barrier prevents the appropriate amount of plasma circulating free DNA shed from the tumor for us to be able to, in fact, make that diagnosis. And can we use the signature on the circulating free DNA to a level where we can discriminate different tumor types? We followed the same protocol as my colleague Daniel DiCarvello has established in his lab and the publication that I showed you. This is a pull down technique where the DNA is isolated and subsequently amplified and sequenced for methylation. We looked at approximately 500 samples, compared gliomas to healthy and the other solid tumor types. We could see that we can compare gliomas versus all other classes with an extremely high accuracy of AUC of nearly 1. When we look at gliomas versus other tumors in IDH mutant glioma and IDH wild type, the accuracy continues to be very high. We then said, well, perhaps the high-grade gliomas are easier to detect since low-grade gliomas, the blood-brain barrier is not intact. But in fact, grade 2 and 3 gliomas, we can detect them and discriminate them from other cancer types with high accuracy, and similarly for grade 4. This is a heat map showing the methylation signature of the brain cancers, gliomas in this case, compared to the other tumor types. And you could see that the methylation signature is very distinct. This is a map of the similar data where you could see that majority of the brain tumors have a very distinct methylation compared to all other cancer types. The correlation of the methylation signature in the plasma to the tissue is very high, again, confirming that what we're seeing in the plasma is in fact reflective of the tumor tissue that we're analyzing. And you could see once again that glioma versus all other subtypes has a very high accuracy in its detection. We then thought, well, perhaps the signature that we're picking up is not from the glioma cells, the cancer cells themselves, and it could be from the microenvironment, inflammatory immune cell population. In order to assess that, we used glioma cell lines and identified a signature and a series of probes that define the glioma cell line methylation signature, as you could see here, compared to other cell types and other cancers. We then applied this signature to the plasma methylation signature, and you could see that the correlation is extremely high, confirming that in fact, the plasma methylation signature we're detecting is from cancer cells and not the microenvironment cells. The next question was, are other cancer types in the brain similarly readily detectable and can be discriminated from one another? You could see that meningiomas, we could discriminate from other cancer types with high accuracy. Hemangioparasitomas, extremely high. We looked at IDH mutant gliomas, glioneuronal tumors that are low grade, IDH independent in their diagnosis. Again, very high accuracy. And glioblastoma or grade 4 gliomas, the accuracy drops to some extent. If you look at the map of how these distribute, you could see that there are some glioblastomas that are distinct from the rest of the glioblastomas. And this, I believe, is related to the very well-known fact that there are different subtypes of glioblastoma. And so the methylation pattern within the plasma varies based on that heterogeneity. So in summary, we were able to publish this in 2020 in Nature Medicine. And we showed that plasma methylation can serve as a biomarker to detect and discriminate between different brain tumor types. The work was done by Farshad Nasiri, who is a PhD student in my lab and a neurosurgery resident. The bioinformatics is Ankur Chakravarti. And again, my colleague and senior scientist partner, Daniel DiCarvello, for the work that they did. This is a group of our neurosurgery residents. We have the largest neurosurgery training program in North America with more than 36 residents in our program, an amazing group of people. And as you could see, I just showed you some of the work that they've done over the last few years. So I hope that I've shown you data that convincingly tells you that at this point of our paradigm, we can in fact modify our understanding and refine and build on what the MRI shows us by adding liquid biopsy using plasma methylation signatures to then make a decision for this young man. Perhaps if we see that it's an IDH wild type, we would be more inclined to offer aggressive surgical resection upfront versus an IDH mutant where we know that it has a better prognosis and slower growth rate. Again, please stop me if there's any questions. The next portion of my talk is to use methylation signatures, not only for diagnostic purposes that I showed you earlier as plasma biomarkers, but as predictors of outcome for patients so that we can refine decision-making. This is the same classification of methylation base for tumors that I showed you, where over 1,000 tumors were analyzed by methylation. And you could see that the methylation signature is very distinct. Can we use this for predictive purposes? Meningiomas can occur anywhere in the cranial axis. Some are very straightforward, are fully resected surgically. Some are more complex, involve the neurovascular structures, and residual is left behind. Meningiomas, in fact, are the most common brain tumors that we deal with. If you look at all brain tumors, 35% of the brain tumors are meningiomas, higher than, in fact, glioblastoma. If we remove malignant brain tumors, you could see that majority of the brain tumors, in fact, more than 50% are meningiomas. If you look at the incidence of meningiomas, there's an increase beyond age 65 compared to other tumors. And if we look at the world map for those that are over 60 years of age by percentage, you could see that majority of the world is in fact aging very well. And so you would expect that meningiomas would be high in incidence, and we would have to deal with meningiomas in our practice more and more as the population ages. Currently, the predictors that we use are not extremely reliable. We use WHO grading, which is graded between 1, 2, and 3. The distinctions are primarily reliant on number of mitosis figures per 10 high power field. And neuropathologists will say that the inter-observer variability for detecting 4 mitosis per 10 high power field versus more than 20 per 10 high power field will be very subjective. Meningiomas have 18 different subtypes under the microscope. Some have aesthetically pleasing appearances, however, have no bearing on outcome for the patient. And so using WHO, though important and gives us a sense of the behavior of the tumor, is not precise or accurate. The next factor that we use is Simpson grading. And this is a grading that surgeons use based on extent of resection. And if it's a grade 1 to 3, it's a gross total resection. If it's a grade 4 to 5 resection, it's essentially a biopsy. And of course, logically, if there is lower degree of resection, the likelihood of recurrence is much higher. Despite this, you could see that if we take tumors with grade 1, 2, and 3, the likelihood of recurrence in grade 1 can still be high, and the likelihood that some grade 3s don't recur is still present. And so our current classification is not precise and could use improvement, perhaps by integrating molecular classification. 2 decades ago, there were seminal papers that looked at mutational landscape of meningiomas, but unfortunately, with increasing grade, you could see that the mutation signature does not increase. Recurrent mutations are present, but only in grade 1 meningiomas. And so unlike gliomas, where IDH mutation is a defining feature of aggressive behavior versus a good behavior, in meningiomas, increasing grade is not associated with a change in mutation, other than really NF2 mutation, which is well known and established in meningiomas. Copy number alteration does increase with increasing grade for meningiomas. However, copy number alterations alone will not be sufficient to provide a prediction for outcome for the patients. We then looked at methylation. Once again, we looked at methylation signature in meningiomas, and in a study that was done collaboratively with Ken Aldapi at the time at MD Anderson, we saw that there are 2 distinct methylation patterns. One where there's a favorable outcome, and the second methylation signature, unfavorable outcome. We then validated these results in a cohort from University of Toronto and found that there are, in fact, 2 distinct methylation signature, favorable outcome and poor outcome. At the same time that we did this study, the DKFZ group in Heidelberg also did methylation on meningiomas, and they identified 6 distinct groups based on methylation with very variable outcome. Most likely, the 3 benign groups are similar to the favorable outcome of our study. Intermediate is the second group, and unfavorable or malignant is the third. So you could synthesize it to 3 methylation groups that exist in meningiomas. We thought then perhaps that we would take the methylation signature and create an individualized nomogram or a calculator to then be able to personalize prediction for outcome for meningiomas. We took a cohort of approximately 250 patients. We analyzed the tumors by DNA methylation. We identified 10,000 probes that were differentially methylated that distinguished good versus poor outcome. And we then applied a series of bioinformatic analysis to create a pipeline that predicts outcome for individual patients, and applied this through validation cohorts to 54 and subsequently 140 and another 100 patients through 3 rounds of validation to confirm that in fact the pipeline that we've created is broadly applicable and layered on top of methylation, the age of the patient, the extent of resection, gender, and WHO classification, in addition to other demographics. And we were able to come up with a calculator that predicted outcome from an individual patient. If you look at the cohort of tumors that we analyzed based on WHO grade 1, 2, and 3, as predicted, grade 1 does well, grade 2 is intermediate, and grade 3 has poor outcome. I would say that the grade 2s and grade 3 meningioma are the most controversial, as following surgical resection, there's often discussion and consideration as to whether the patient would benefit from radiation or could have radiation deferred. We looked at the methylation signature independent of the WHO grade, and similarly, based on the methylation predictor that I just showed you that we created, the tumors have a favorable outcome, intermediate, and very poor. We looked at each WHO grade classification separately to show that the methylation signature is independent of the WHO grade. WHO grade 1 meningiomas based on methylation, majority do well. However, there is a subset that are in fact quite aggressive and have a worse outcome. WHO grade 2 meningiomas based on methylation, there's a subset that do very well, and I would argue that this group should have radiation deferred or delayed. There's a subset that do extremely poorly, and perhaps they warrant upfront radiation, and an intermediate group that needs discussion as to what the next steps are following surgical resection. WHO grade 3, we all appreciate that these are aggressive tumors. However, as I showed you in our own institutional data, there is a subset of tumors that do well as WHO grade 3 tumors, and so they most likely would benefit from having radiation withheld. So how does the calculator work? It has 100 points. Grade has a weight of approximately 50. And so in a hypothetical case, a grade 2, WHO grade 2 gets a score of approximately 25. Simpson grading has a weight of approximately 20%. The surgeon tells you, and the MR images post-op tell you, that there was an extent of resection of Simpson grade 3 with a weight of approximately 10 scores. The methylation has 100% one-to-one weight in the calculator. And when we calculate it based on the pipelines we've created, the weight of that puts us at approximately a score of 60. Cumulatively, this brings us to approximately 90 points, which then tells us that the 5-year recurrence-free survival for this patient sits at 0.4. The inverse of that is 60% chance of recurrence at 5 years. This then warrants discussion in tumor board as to whether we would withhold radiation or give radiation upfront. So you could see that in this section of the paradigm, postoperatively, we have the diagnosis of meningioma and the WHO grade. We then do methylation and come up with a nomogram that predicts the aggressive behavior of the meningioma, and discuss this currently at our tumor boards as to whether we should give radiation or withhold radiation. These are examples of patients where the tumor is resected, and you could see this is a convexity meningioma operated on at an outside institution. The resection is good. The WHO grade of this tumor is reported to be 2. The extent of resection Simpson grade is 4. The methylation predictor that we identified is 0.985. The 5-year recurrence risk of this patient is quite high, and you could see that at 33 months, this tumor recurred. A similar patient, outside institution, resection is very good. WHO grade is 2, extent of resection Simpson grade 4. Prediction for 5-year survival, however, is a much lower score, and 72 months, this is now approximately 2 years ago even, the tumor remains not recurrent, and there is no evidence of recurrence with no radiation. So hopefully I've shown you that this predictor is in fact practical to use in our clinical practice, and we are able to integrate methylation into our decision-making for meningiomas. And as I indicated, currently, this is our practice at the University of Toronto, at Toronto Western, where we incorporate methylation for decision-making for our meningiomas as to whether they benefit from radiation or not. The last portion of my talk, I want to show you how integrating molecular patterns of tumors can in fact improve our understanding of the biology of the tumor, reveal targets for therapeutics. In the era where molecular analysis of tumors are done, the question remains, which of the platforms do we rely on? RNA sequencing, expression data, methylation, as I showed you, or copy number alteration, or mutation patterns. We took a cohort of approximately 200 meningiomas and analyzed that 200 meningiomas with multiple different platforms: RNA expression, methylation, copy number from whole exome sequencing, single cell data, proteomics, etc. As you could see, based on RNA analysis, meningiomas divide into 6 distinct groups, and each of the groups have very distinct outcomes. If you take methylation and cluster based on methylation, data that I showed you, you could see that there are again 6 different clusters with 6 very distinct outcomes. If you look at copy number alteration, once again, that same cohort of tumors, it's the same 200 tumors analyzed for copy number alteration. There are 6 distinct outcomes. But you could see that these 3 different platforms are not the same, and the patterns of outcome are not the same. In fact, membership of the tumors to the different platforms, though they produce 6 different clusters in each platform, are not the same. So if you fall within this category based on methylation, you do not fall into the same group based on RNA expression, and not the same in copy number. There's a significant crossover of membership between the different platforms. So the question then is, which of these are most clinically reliable? And the answer is that not one single platform provides the best solution, but rather combining the different platforms through a cluster of cluster analysis, where we combine copy number, methylation, and RNA expression to produce recurrent patterns of classification into 4 classes: meningioma 1, 2, 3, and 4. And you could see that each of these groups are independent of the WHO grade, independent of the extent of resection, and rely on it being defined based on copy number alteration, methylation, and RNA. Some groups rely more so on RNA than others, and some rely more on copy number alteration. The 4 groups classified as MG1, 2, 3, and 4 have very distinct outcomes. These are stable groups where the 4 subtypes reproduced in different validation cohorts based on the RNA expression, independent of WHO grade, in fact, predict outcome better than WHO grade, and independent than the methylation classifier that I showed you earlier. We then looked at the expression pattern of these 4 groups using the RNA data and looked at RNA pathways to define and understand the biological significance of these 4 groups: MG1, MG2, MG4, and MG3. And you could see that each group has very distinct RNA pathways that define them. MG3 are hypermetabolic, depend on metabolic related pathways. MG4 are hyperproliferative, depending on proliferative pathways. MG1 are immunogenic, depending on immunogenic, immune infiltrative, and macrophage related pathways. And MG2 are primarily angiogenic with relationship to blood vessels, vessel sprouting, and angiogenic factors. Each of the MG groups have distinct mutational patterns. Notably, you could see that MG2, in fact, although we recognize meningiomas to have NF2 mutation, MG2s are very limited in the NF2 mutation patterns that we see. So defining, again, a very distinct biological subtype. The other advantage of doing RNA pathway analysis is that we could also look at drug screening and ability to identify targeted therapeutics. And an example is that we were able to show that vorinostat can in fact target the MG4 tumors. You then ask, well, if we're not able to do molecular analysis to the extent of doing RNA expression, whole exome sequencing, and methylation, how would we be able to translate this into a day-to-day clinical laboratory that we use in each of our labs at all of our institutions? And this is where proteomics became handy. We took the same 200 tumors and analyzed by proteomics. And you could see once again, based on proteomics, there are the 4 stable groups of meningiomas, with each of the groups defined by a unique protein that could be analyzed by immunohistochemistry. So now each of the groups, MG1, 2, 3, and 4, can be identified based on a specific antibody. S100 is only unique to MG1, SCGN only unique to MG2, ACADL unique to MG3, and MCM2 unique to MG4, with very high accuracies, reasonable for laboratory testing. And so we can integrate this into our clinical practice pretty much at every institution to be able to identify MG1 through MG4. I showed you that vorinostat was a compound that was identified through the RNA expression pattern. we created meningioma cell lines based on the tumors MG1, 3, and 4. And you could see that if we use 5-azacitidine, the impact on the different lines is minimal. However, if we use vorinostat, it decreases the growth of the MG4 cell line compared to MG1 and MG3, confirming that it is very specifically targeted to the MG4 pathways. And you could see that in animal models, we could decrease growth of the tumor and increase survival. This was published this year, August 2021 in Nature, again, recognizing that there's a large group of people that contribute to this work. Farshad Nasiri is the first author. Jeff Liu, Vikas Patel, and Yasin Mamajan are the bioinformatics in this paper. And a long group of, a number of people that contributed to the study, Ken Aldape, Thomas Kisslinger, Dan DeCarvalho, and many others who helped us with this project. This is a cartoon summary of what I showed you to date, which is that there are distinct methylation, RNA expression, and copy number alterations that, if they're combined together, can produce immunogenic NF2 wild type, hypermetabolic, and proliferative meningiomas. Each have very distinct outcomes with good to poor. Each have specific proteins that could be targeted by immunohistochemistry, and data that I didn't show you for interest of time on single cell analysis have very distinct single cell patterns of behavior, demonstrating the same biology that the cluster of cluster revealed to us. I would like to present also our International Consortium of Meningiomas, which is over 32 institutions across the world, and we invite participation from all institutions. We publish on key topics related to meningiomas, and in the past, we've had over 10 publications by the consortium. The paper that I just showed you of molecular analysis is made possible by integrating data from multiple institutions. And I'd like to thank the agencies that fund the work that we do, but most importantly, all of the people that help make the research projects possible, and yourselves for your attention. This was our meeting in Boston 2021 for SNO, and I hope that if you have an interest, you become more engaged with the society as well. Thank you for your attention, and thanks again for inviting me.
Please unmute your mic, Professor Narita.
Can you hear me?
Yes, Professor.
Okay. Thank you for nice lecture. So Dr. Zadeh shows a molecular diagnosis based on methylation array becomes more important. So do you have any question from the audience?
Yes, I would like to start with one. Thank you very much, Professor Zadeh. It was indeed a very mind-boggling lecture. We are listening to the stupendous advances that have been going on in your institution. Really, it is awesome, and we learned a lot today. I would like to ask whether have these scores like Toronto meningioma recurrence score, has this been validated by externally by different authors?
Yeah, so that's a good question. I don't think that formally it's been validated, but we continue to provide the predictive score using the nomogram for multiple institutions within and outside of Canada. So other institutions have adopted using the predictor. And in fact, Ken Aldape, who used to be in Toronto and moved to the NIH to be the head of pathology, sends the samples to us to do the prediction score and gives the results back to other laboratories as well across the world. So in a sense, although not formally perhaps validated by a second group, it has been undergoing constant validation because other institutions are using it. And we have now over 500 samples of meningiomas that we've analyzed by the predictor.
Thank you very much. Another question that I would like to ask is the imaging of gliomas has come a long way, and today they can actually, the MRI patterns of contrast enhancement has been used to predict the IDH nature or the wild type nature in gliomas. How often do you use this in your clinical practice?
So that's a very good question. I think MR spectroscopy helps in predicting the IDH status and 2HG, for example, levels for gliomas. At our institution, our imaging analysis doesn't really use MR spectroscopy. A lot of it is based on how our healthcare is funded. So we don't have MR spectroscopy as part of the funded element for our patient. So I couldn't really comment directly based on personal experience, but definitely literature shows that you can use MR spectroscopy to predict with some accuracy the IDH status of the patient. However, I think the plasma analysis that I showed you has more accuracy. The AUCs and the region under the curve demonstrate a higher accuracy for these tumors to distinguish the IDH status.
Thank you very much. I would
My
like
pleasure.
to open this for further questions. Here's my co-host, Dr. Liu Bun Singh.
Thanks, Raja. Thank you, Professor, for a very nice, interesting discussion and topics presentation. I have a few questions, Professor. First, because in glioma especially, we are talking about tumor burden. And always we look at how many percent tumor was removed. And in your classification, I don't see any component of the size of the tumor when you make the prognostication. I just want to know how much this tumor burden that we always use in glioma that help to predict the outcome. My second question, Professor, your outcome or your Kaplan-Meier's curve is very much depending on the modifier such as surgery, radiation therapy, and chemotherapy, and they are not a natural cause of the disease itself. How do you actually look at this modifier and make a better prediction of prognosis of this patient before treatment started? My last question, Professor, in the change of diagnosis that you apply in your practice, do you ever compare to your historical cohort? Does it actually have a better progressions-free survival, Professor? Thank you.
Okay, so let me see if I remember all the questions. For the predictor, we only use the predictor for gliomas. Sorry, for meningiomas. We don't use it for gliomas. The size of the tumor was one of the factors that for meningiomas that we integrated into our calculator and was not significant. And so it didn't come out in the calculator that I showed you. Only WHO grade, extent of resection, and the methylation signature or the methylome were significant, and that's what populated the nomogram. For gliomas, it would be interesting to do that sort of predictor. The issue really is for glioblastoma, you don't have a wide range of outcome, unfortunately, currently to be able to integrate that. On the point of the size of the tumor, we are looking at the size of the glioma at the time of diagnosis to the content or concentration of DNA that we see in the plasma circulating DNA to see perhaps is the location of the glioma or the size at the time of diagnosis determining the ctDNA content. It certainly doesn't influence the methylation signature there. With respect to your question for methylation on a historical cohort, looking retrospectively on their outcome, that's an excellent question. If we had, the human power, people power to go back and look at our cohort and analyze it by methylation, that would be an amazing project to do. It's really a matter of finding research dollars to be able to do that. What we are doing that perhaps is answers that question and maybe in fact a little bit broader is we are analyzing prospectively how our methylation matches our histopathological diagnosis when the pathologist is blinded to the diagnosis. So in other words, what's the discrepancy between histopathology and methylation if the pathologist was blinded? And more importantly, looking at the predictor prospectively for the meningiomas to see, instead of looking back and saying, well, yes, this tumor didn't recur over a 5-year period, all comers moving forward, is this nomogram accurate? And that would add another layer of validation. I forget the third question that you asked. Sorry.
You have answered all the questions, Professor. Thank you.
Okay. All right. Thank you.
Thank you. Thank you very much. Yes, we have a question from Dr. Selfie
Okay.
Oswari from, yes, Professor.
I have one question. So
Yes.
regarding to meningioma recurrence score, so if the patient shows high meningioma recurrence score, so how do you manage the patient? Do you do radiotherapy for that patient?
Well, so it's interesting because if it's a grade 1 meningioma with no concerning features and the methylation shows a high recurrence score, we will discuss perhaps a closer observation. And if there's a significant residual, we would do radiation. By contrast, if it's a WHO grade 2, but we've been comfortable with the extent of resection as surgeons, and the methylation shows that, in fact, the recurrence score is low, we currently withhold the radiation.
Okay.
So it does, and that's an area that we're studying, so that although we've incorporated into our practice, we can prove, objectively whether, in fact, we can use the predictor to determine recurrence following radiation or response to radiation.
Yeah. And regarding to plasma methylomas, so how many percentage of patients can be detected plasma methylome? How many patients?
How many samples did we analyze?
How many samples? And
well, so for the paper, we analyzed about approximately 120, but since the paper, we now have about 600 samples.
And all patients could be detected plasma methylome?
Yes, so far of the 600, approximate 600 samples that we have, we could use the methylation signature. We're now looking to see whether the methylation signature can be used to follow patients longitudinally.
Okay. We can take one last question from Dr. Selfie Oswari, who has joined us from Jakarta National Brain Center. Yes.
Thank you very much, Dr. Raja. Oh, it's so nice to see you again, Dr. Zadeh. Thank you for sharing your transformative research. And I do have just one small question, I guess. What do you think about the intratumoral DNA methylation heterogeneity in GBM, and how does it will affect DNA methylation as a biomarkers?
Yeah, it's nice to see you, Selfie. And thank you for agreeing to be a co-chair with me for World Federation of Neurological Surgeons.
It's my honor.
So it's a good question. The intratumoral variability is very, very little for methylation. And so that's why I think we can rely on using the circulating tumor methylation as a marker of the tumor. Now, that said, what we haven't done is look at the variability that's created as a result of treatment to see whether perhaps there's methylation signatures that are variable following chemoradiation.
Right. Thank you. Thank you very much, Professor, for that answer. I think we can wind this session and hear the final concluding remarks from Professor Narita.
Great. Thank you very much again for the invitation.
Thank you. Thank you very much.
Thanks again for this opportunity. It's great to see you, and hopefully I see you in person at some other meetings.
Definitely. Thank you very much. I would like to inform our viewers that this is being broadcast on the WeChat channel as well. And today we have more than 700 people who have joined us live. Thank you very much, Professor Shubin, for airing this on the WeChat channel in China as well. Professor Narita, thank you very much. Professor Zadeh, thank you very much. So we'll
congratulations. Thank you.
Thank you. We'll move on to bye-bye. We'll move on to the second session, and I would like to invite Professor Yadram Yadav to say the introduction part.
Good evening. So the second talk is by Professor Takiyatsu. Before he talks, I'd like to just introduce a little bit of thing regarding the retractor. That is tubular retractor or cylindrical retractor. We also use indigenous retractor in our practice. So regarding a little bit of, regarding the deep-seated tumor or maybe intraventricular tumor, the difficulties a neurosurgeon faces are difficulty to maintain the corridor because the lesion is deeper. There may be difficulty in bimanual dissection using a channel endoscopic surgery, which I'll come. And then there is a risk of injury to the overlying brain when you introduce instruments and reintroduce instruments. There may be poor visualization, especially when you use channel endoscopy and irrigation in water media. So all these difficulty we need to overcome by something. So these difficulties are not only overcome by the endoscope itself. So you need some additional tool, and that tool is possibly the tubular retractor. There is also difficulty in control of hemorrhage, especially using the liquid media. And also there are problems when the lesion is very large and vascular. So taking help of possibly the tubular retractor, we can deal with these problem which we will be discussing and listening to Professor Taki UT later on. Regarding the endoscopic surgery, mainly there are two types of endoscopic approach. One is the channel endoscopic surgery, in which we usually do ETV and some of the intraventricular tumors. It is pure endoscopic surgery. The instruments are passed through the working channel. So therefore, there are limitations. There is difficulty in bimanual dissection. There is difficulty also in controlling if there is a severe bleeding. And if the liquid medium is used, then it is really difficult to see from where it is coming. And because of these limitations, these are mainly indicated when you have a smaller lesion or the lesion is avascular. You need specially designed instruments, and there is a small opening. So, but when you use tubular retractor or cylindrical retractor, which Professor is going to talk, then some of these difficulties like bimanual dissection becomes a little easier. You can control the bleeding, even if it is severe, and the large lesion or even the vascular lesions can be managed. But there are limitations, so I'll not take much of time. There may be problem of migration of the tube or the cylinder. There may be injury to the brain, especially if the tubular retractor or cylinder migrates out. So putting them back again may cause some injury. Then the retractor may become unstable. When there is a very large lesion and you put in cylinder, after excision of the large tumor, it may become unstable. So there are tricks in managing those things, which I am sure Professor will talk. There may be brain fall when the lesion is large, and apart from, so the brain may fall away from the dura mater, which also need to be addressed. And there may be learning curve, which is there in all surgery. And these cylindrical retractor obviously are not suited when the lesions are superficial. So with these comments, I think it is better that we listen to from the expert, Professor Takiyasu. Please.
Thank you very much. Good evening, everyone. I'm Dr. Takeuchi from Nagoya University, Japan. Today's my topic is endoscopic cylinder surgery for ventricular regions. Firstly, I want to introduce cylinder surgery. Surgical treatment for deep-seated region is still challenging. Surgeons should pay attention not to damage the normal brain during the removal procedure. various kind of brain retractor was invented and used for all these deep-seated regions, including the ventricular tumors. This is a review report. In this report, tubular retractor was introduced as the most successful retractor. In the usual spatula, the retraction pressure is applied only one direction, and that is cause of the retraction injury. But in the tubular retractor, it can distribute the retraction pressure evenly, so we can reduce the risks of retraction injury. In 1988, Professor Kelly introduced cylinder use in the neurosurgery. They used a 2 centimeter diameter cylinder and inserted it with a straight tactic maneuver. And the visualization was performed with a microscope like this. In 2009, Professor Kasan reported endoscopic use in the cylinder surgery. They use a 11.5 millimeter translucent cylinder and inserted it with navigation guidance. After this report, endoscopic cylinder surgery report is increased. But recently, there have been more and more reports of the cylinder surgery using exoscope instead of endoscope. That is because there is a big disadvantage of endoscopic use. That the most important one is occupying the surgical space by endoscope. As for cylinder surgery in Japan, most of the reports of cylinder surgery are using endoscopes. This is largely due to the fact that cylinder surgery in Japan originated from endoscopic hematoma removal surgery. The endoscopic hematoma removal surgery was invented by Dr. Nishihara in 2000. A very sensational report of hematoma removal. This surgery was performed with a 6 millimeter diameter cylinder. This surgical technique is widely used in Japan. Since it is difficult to obtain an optimal view from the outside with a small diameter cylinder, like a 6 millimeter diameter cylinder, the use of the endoscope is advantageous. It is thought that the use of endoscopes was easier to generalize because we started with smaller diameter cylinders compared to other countries. Then move to the surgical techniques. This is cylinders. Now, I mainly use these types of cylinders. 6 millimeter diameter neuroport or 10 millimeter diameter neuroport or view side tubular retractors. This is how I introduce the cylinder. Endoscope tip is calibrated by a navigation system like this. We put the adapter array on this side and calibrated it with a navigation system. And when insertion of the cylinder, we use this type of translucent test-up needle. This test-up needle have a 3 millimeter lumen, so we can insert the endoscope inside the test-up needle like this. For doing so, we can notice the location of the endoscope with the navigation guidance. And also we can get a direct view of the tip of the needle like this. we can accurately insert the cylinder to the region. This is a surgical maneuver. The cylinder is held by assistant, very gently like that. And 2.7 or 4 millimeter endoscope is inserted inside the cylinder. And 1 or 2 thin instrument are also inserted very coaxially. And drip line is also inserted inside the cylinder to fill it inside the cylinder and inside the ventricle. Removal technique inside the cylinder is divided into two: one-hand surgery and two-hand surgery. This is one-hand surgery. This one-hand surgery, I hold the endoscope and suction tube like that. The sheath is held by an assistant, and the main surgeon holds the endoscope and the instrument. In this technique, it is possible to change the direction of the cylinder and the operation field dynamically by tilting the sheath like this. This surgical technique is very useful for hematoma removal surgery and suckable tumor surgery. But this technique cannot be adapted for hemorrhagic tumor or hard tumor. On the other hand, this is a two-hand surgery. We can use various kinds of the instruments in this technique. The cylinder is held by assistant like this, and the endoscope is held by endoscope holder like this. This one. It is easy to achieve the precise dissection and the hemostasis. And tumor debulking is also possible because we can use scissors or CUSA. And this surgical technique is useful for the eloquent area tumors and hemorrhagic tumors. But in this technique, we have to use a larger diameter sheath generally. If you use a larger diameter sheath, surgical maneuverability improves, but surgical corridor becomes large. So we have to choose the cylinder size case by case. I want to introduce a wet field technique. Endoscope gives a bright and wider view even underwater. This is inside the brainstem. We can see the venous anomaly like that. And water pressure expands the tumor bed very naturally. Of course, we can expand the ventricle very naturally. This is wet field, and this is dry field. We can expand the tumor bed. Of course, we can expand the ventricles like this without any additional retraction. And in this technique, it is easy to find a hemorrhagic point like this. So we can coagulate the hemorrhagic artery with pinpoint coagulation like this. This is very useful in the eloquent area tumors. Of course, we have to use various kind of specific surgical tools. Like this one. This one is a rotatable dissector. This rotating movement doesn't require the shaft movement. In the cylinder surgery, the interference between the instrument and the endoscope is the most important problem. But in this surgical technique, rotating movement does not require the shaft movement, so it's very easy to adapt this in cylinder surgery. And of course, the coagulation, in the coagulation, we have to use a bipolar coagulator. This type of same malleable bipolar forceps is very useful in the cylinder surgery. Okay, now let's move to the case lessons. Firstly, I want to introduce lateral ventricle regions. This 50-year-old male appeared with a headache. At first, tumor size is very small, but the tumor got bigger and bigger, so we decided to perform the tumor removal in this case. But this patient doesn't have a hydrocephalus, so the ventricular size is intact, very small. Because the shape of lateral ventricle is broad, so compared to the ETV surgery, hole should be made more anterior side and more medial side. Otherwise, we can reach to this part. Patients have relatively narrow ventricles. If we evacuate the CSF, the ventricular size become very narrow. So surgical field should be filled up with water to keep the ventricular size. Of course, the removal procedure should be performed with a rigid endoscope, but we cannot see this area with a rigid endoscope. So with a flexible endoscope to observe the entire ventricle. This is surgical video. We made a 3 centimeter small craniotomy like that, and then insert the cylinder to the lateral ventricle. This is foramen low. Now we are dissecting a tumor from the ventricular wall, like this. The tumor was removed piece by piece fashion. Almost all procedure was performed underwater. So we performed the removal procedure in the relatively wide surgical field like this. Unfortunately, this tumor was not a hemorrhagic tumor. So we could dissect and remove it. This. And evacuate the tumor like this. After the most part of the tumor is removed, we observe the posterior side with a flexible endoscope. There's a small tumor remnant. So we remove it like this. And very good removal was achieved. The surgical corridor was minimal like this. So I think the generally the central neurocytoma is less hemorrhagic and relatively soft. So it's very good indication for endoscopic removal. The next case is a 73-year-old female. She appeared with consciousness disturbance. MRI revealed the relatively large trigon meningioma, like that. Unfortunately, this tumor had vessels like that. Maybe feeding arteries come from the corridor artery here. So this is our surgical strategy. we cannot remove it with a hyperlateral approach alone. So we approach, we use the double cylinder surgery. We insert the cylinder from the high parietal area and also inserted the cylinder from the temporal area like this. Firstly, we insert the cylinder from the temporal area and coagulate the feeding artery, and then insert another cylinder and remove it. This is surgical video. We made a small skin incision and insert a 6 mm diameter cylinder. This is a inferior horn of the lateral ventricle. We coagulate the feeding artery like this. We perform the two hands technique and feed most feeding artery was coagulated. After that, we insert a 10 mm cylinder from the parietal area like this. Unfortunately, the tumor was relatively hard. So with the scissors like this, we harvest the tumor specimen, and the hemorrhage was not so severe because we stopped the we coagulate the feeding artery at the early stage of surgery, and we can also use CUSA like this. After the adequate decompression, the tumor was dissected from the lateral, ventricular wall. We perform the debulking again and dissect it. This is another cylinder here. Unfortunately, the tumor was severely adhered to the thalamus. So we leave the small tumor remnant here. But most part of the tumor was removed. Like this. We confirm the complete hemostasis and the water. This is post-op MRI because a small tumor remnant was seen here, but most part of the tumor was removed. And the surgical corridor is minimal, like this. So cylinder surgery is enough less invasive for simultaneous multiple approaches. And the double cylinder surgery, of course, we can choose a triple cylinder much more. This surgical technique can enhance the safety. Now, let's move to the third ventricle regions. This 27-year-old female appears with a headache, and MRI revealed a mild hydrocephalus like this. And the tumor was located in the third ventricle, relatively small one. And this is our surgical strategy. Patient had a very mild hydrocephalus, and the tumor is relatively small, enough small to remove with a 6 mm diameter cylinder. And 6 mm diameter cylinder is small enough to insert into the foramen of Monro. This is surgical video. We insert the 6 millimeter diameter cylinder to the lateral ventricle. This is a anterior septal vein. We dissect it and cut it to enlarge the foramen Monroe like this, and then insert the cylinder to the third ventricle. This is massa intermedia. The tumor was covered with covered by the massa intermedia, so we dissect it, cut it. The tumor had a calcified component, but fortunately the tumor was not so hard, so we could remove it with a piece by piece fashion, like this. After the decompression, we are dissecting the tumor with a rotating movement and opening and close movement of the forceps, like this. Then remove it. And damage to the foramen Monroe is minimal, like this. This is a post-op MRI. The most part of the tumor is gone, and the surgical corridor is minimal, like this. Another case is a posterior third ventricle case. 5-year-old male with a headache and vomiting. The patient had a severe hydrocephalus like that. Tumor was located in the pineal area, and but the most part was located in the posterior third ventricle. So, as like as the previous case, a 6 millimeter diameter cylinder can be inserted into the third ventricle. Of course, there is a massa intermedia here. We can cut it like this. So we inserted the cylinder. We inserted the 6 millimeter diameter cylinder. At first, we cut the massa intermedia in the middle. After that, the anterior septal vein was dissected and coagulate and cut it. After that, this is a tumor. This is a cerebral aqueduct. We dissect the tumor from the surrounding brain, because this is a immature teratoma. So we want to remove it with an unblocked fashion. So we coagulate the feeding artery from the lateral side with a very thin bipolar coagulator. We coagulate the feeding artery. This is the most deepest side. There is various feeding arteries around this area. So we coagulate and cut. But the tumor was severely adhered to the basal vein, so we divided it into two. The main part of the tumor was removed, but the tumor was relatively large compared to the cylinder. So we remove it after the removal of the cylinder. After that, we remove the residual tumor like this. So the gross total removal was achieved, and the damage to the fornix was minimal, like this. This is a post-op MRI. All tumor was gone, and the surgical trajectory was minimal, like this. So the this cylinder surgery is very useful for the third ventricular tumors. The last one is fourth ventricular regions. Nowadays, I perform the cylinder surgery for the fourth ventricular regions. This 59-year-old male appeared with a double vision and left facial palsy, and MRI revealed the pontine carcinoma, like this. But the tumor was mainly located in the fourth ventricle. This is our surgical strategy. The foramen majority is a relatively narrow foramen, but I think I thought the 6 millimeter diameter cylinder is small enough to insert into the foramen of majority. That is because there is no adhesion between the bilateral tonsil. The inferior border of the vermis is here, so we can insert the cylinder along with the inferior border like this. But compared to the usual craniotomy, we have to make a skin incision and craniotomy a more caudal side. This is surgical video. We made a 5 centimeter skin incision and 3 centimeter craniotomy was made. And the V-shaped dural incision was performed. There is no adhesion between the bilateral tonsil, so we can insert the cylinder very smooth, like that. We can get into the fourth ventricle. Of course, we perform the direct cortical stimulation to confirm the location of the facial nerve. And first, we evacuate the hematoma component, then dissect the tumor from the brainstem with the opening and closing movement of the forceps. We remove the carcinoma piece by piece fashion, like this. We are very gently dissect the carcinoma. And the carcinoma was removed, like this. Gross total removal was achieved. This and damage to the brainstem and the tonsil was minimal, like this, no damage. Post-op MRI showed the gross total removal and no damage to the cerebrum tonsil here, like this. So this cylinder surgery can also be adapted for the fourth ventricular regions. So the conclusion is here. Endoscope is useful for interventricular regions, almost all interventricular regions. Surgical planning is essential for this surgery. And wet field technique and water surgery is very useful to keep the ventricular size. But some specific surgical tools is required for this surgery. Thank you very much.
Thank you very much, Professor Takeuchi, for excellent talk and good demonstration of cases. So before this is open to the audience, I'd like to ask what are the size of your instruments? Because you said the most of the surgery, especially intraventricular surgery, you use 6 mm cylinder. So, and you use 2.7 mm endoscope in it. So very small little space is available. In case you need two instruments to put in, there is hardly any space available. I know that you are using the angle tip instrument for manipulation because linear movement is impossible. So what is the size of your instrument, number one?
I mainly use 2 millimeter suction, 2 millimeter or 2.5 millimeter suction, and 1 millimeter forceps. I like it. I think the forceps can be available in your country. I use made in Pakistan forceps, not made in Japan. Very cheap forceps, but the size is very small, so I like it.
Excellent. So one important aspect is that you need to use single shaft instruments, and it should be thin. Then only you can use two instruments. Otherwise, there's a limited space. The another, comments from you is that if the lesion, you have said that most of your lesions which you removed, except the meningiomas, were small and avascular. So if there's a large lesion and if it is vascular, and unfortunately, if the blood supply is not coming from one place like in meningioma, that was fine. But if it is coming from this and there's a bleeding difficulty, did you find some difficulty in bimanual dissection, especially using a small tube?
Of course, I sometimes encounter the severe hemorrhage during the mini cylinder surgery, like at the 6 millimeter diameter cylinder. I changed the cylinder size to a larger diameter. Of course, I perform the larger size craniotomy in all cases. I usually perform the 2.5 to 3 centimeter craniotomy. So if I encounter the severe hemorrhage, we can change the cylinder to the maximum diameter is 2 centimeter. 2 centimeter is very, I think it's enough.
More than enough. More than.
But I use I've never used a 2 centimeter diameter cylinder. I usually use maybe 50% of the tumor removal can be done with a 10 millimeter diameter cylinder. I think the 10 millimeter is large enough. If you have enough good surgical instruments.
Excellent, sir. The other thing, you have such a nice skill and thing. Please tell the audience what are the limitations, because that is also, otherwise everybody takes the message that anything can be done. So what are the limitations, and if you have come across some of the difficulty, how you control that? I mean, how to manage the complications, and what are the complications in the surgery, please?
I think this surgery have a very steep learning curve. So at first, if you don't have any experience, you have to perform the you have to start from the less than 3 centimeter tumors and non-hemorrhaging tumors. Maybe I think the choroid cyst or the central neurocytoma case or the cavernoma case, that is a very good indication for this patient, so for this surgery. But after that, after 30 case or 40 case, you can challenge the larger diameter, larger tumors, maybe. But before starting this surgery, you have to prepare the surgical instrument. That is the key.
Okay. any incidence of using a dry field technique if you come across hemorrhage?
Yeah, sometimes. But if I encountered not so severe hemorrhage, I fill up with water and just rinsing. I published one article compared to the dry field, the wet field can stop the bleeding much earlier. So just rinsing is enough for most of the hemorrhage. But if the rinsing is not effective, we suck up the CSF and change to the dry field and stop the bleeding.
Okay, excellent, sir. Any other question? I think we don't have any question in the
So far,
question
we do
box.
not have any questions, but definitely I would like to ask Professor Takeuchi, how did you migrate from hematomas to tumors, or directly did you go on to take on the tumors?
Of course, I started this surgery with from the hematoma removal surgery. Hematoma removal surgery is a very simple and effective technique, and that is very good practice for surgeons.
Yes.
And maybe 50 case I experienced hematoma removal surgery, then move to the tumor removal surgery.
Thank you very much. Yes, my co-host Liwun Singh, any questions from you?
Thanks, Raja. Thank you, Professor, for a very nice presentation. I just want to find out from you, Professor, you did a surgery of hot ventricular carcinoma, and you prefer wet field than the dry field. In that case, what is the advantage of wet field when you come from a foramen of Magendie? My second question, Professor, regarding posterior third ventricular tumor, especially those with a small foramen of Monro, do you think that any advantage to come from lamina terminalis? And if you come from lamina terminalis, is there any option to have wet field in that approach? Thank you, Professor.
First one is wet. I like wet field. Most of the cases I use wet field technique because after you experience wet field and dry field technique, you will like a wet field technique. That is because wet field gives us a very wide surgical field, and if the hemorrhage is stopped, the surgical field become very clear. There's no red blood cell inside the surgical field, so we can detect the tumor without any trouble. So I like wet field even for the carcinoma cases. And the next one is the laminar terminalis. I don't perform the translaminar terminalis approach for the third ventricular regions. I usually perform the trans-Monro approach or infratentorial approach for the pineal regions. I dislike the laminar terminalis approach because I don't injure the hypothalamus. There's a very important structure just behind the lamina terminalis. So I prefer to use the trans-Monro approach.
Thank you, Professor.
Okay, so if there are no other questions, I would like to ask one more problem which I faced. I do endoscopic surgery using a larger tube, which is very inexpensive. In some cases, very large tumor, and very large tumor, as in India, we come across larger tumor. And the ventricle was also very large. So after I removed the significant tumor, my tubular retractor became unstable. And of course, I think one of the reason maybe that I use dry field technique. So in that case, the whole brain fall away, and then I could not work with the tubular retractor, so I had to take help of the conventional retractor to complete the surgery. Did you find some experience of your tubular retractor become unstable, especially if the tumor is very large with huge ventriculomegaly?
I don't use a larger diameter cylinder. I said earlier. I use only a 10 millimeter or 12 millimeter diameter cylinder. If I have to treat the huge tumors, I don't choose a larger diameter cylinder. Maybe multi-port surgery I choose. And most removal procedure will be performed with a wet field. After evacuation and after the ventricular system shrinked, if I fill the CS water inside the ventricle, the ventricular size cannot be returned immediately. So I keep the wet field for larger diameter tumors, larger tumors. And I've never experienced an unstable cylinder because the assistant always holds the cylinder.
Okay. Assistant holding cylinder.
Yeah.
So we face this, and to overcome this problem, what we did, because we are using the same minimum size length sheath. So what we did in later part, when the tumor is very large, we apply a pile stitch to the dura so that it doesn't fall, and this problem was overcome. Thank you, sir. Excellent talk and good experience. I think Dr. Raja.
Yes, thank you. Thank you very much. I think if there are no further questions, we can wind this up. And I would like to close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to sincerely thank both the speakers of today, Professor Jalarizade and Professor Kazuhito Takeuchi, and the chairs, Professor Yoshitaka Narita and Professor Yadram Yadav, for the time and support for the educational initiatives of the ACNS. A special thanks to Professor Shubin for supporting us in our educational ventures and broadcasting these webinars in China. Today, there are more than 700 people who are watching us live on all combined platforms. A special thanks to my co-host Liu Bun Seng for joining me today. So until we all meet on the coming Saturday, it is bye-bye from all of us. Thank you very much for joining.